Hi, this is Dr. Jonathan Youssef, Networking for Your Optimal Health. Today's topic is going to be about skin cancer screening, and in particular, we're going to be talking about melanoma. So this topic is a little near and dear to my heart because a couple of years ago, I ended up diagnosing my father with melanoma, and we did a short biopsy in the office, ended up being stage 1 or stage 2. Luckily, it was resected by a specialist and pretty much was curative for him. So this topic is kind of interesting. I have with me two PA students from South University, Katie and Rebecca. And I think Katie wants to start first, and she's going to talk to us a little bit about screening for skin cancer.
Yes, so screening for skin cancer is great. It's something that everyone can do in their home, and it's as simple as A, B, C, D, E. Essentially, the A means asymmetry, B is border, C color, D diameter, and E evolution. So A is really any asymmetry of the mole or lesion that's presenting itself. So if you can't fold it in half and it folds onto itself, that would be considered asymmetry. The border is typically rough, a little hard to draw around with a pencil, kind of jagged edges, things like that. C is the color. So melanoma often presents with multiple colors, different shades of a color, red, brown, even black. D would be the diameter. So anything that is larger than the size of a pencil eraser, which is about 6 millimeters in diameter, would be concerning for melanoma. E is evolution. So any sort of change that happens to a pre-existing mole would be something that you would want to take care of and go in and see your primary care provider to just evaluate it. Also helpful to do kind of skin checks on yourself just to monitor these things. If you notice really any change to a pre-existing mole or something that pops up, suddenly, that would be a concern as well.
Absolutely.
Okay, and then just going back to the skin checks, something to do for prevention is to seek shade when it's appropriate. The sun's rays are strongest between 10 to 2, so if your shadow is shorter than your shade, definitely time to go back in. You should wear protective clothing. There's a lot of clothing with SPF in it right now. And then also use broad spectrum sunscreen with SPF 30 or higher. So about a shot glass to your body, and you should reapply the sunscreen every 2 hours after swimming or sweating. And then use extra caution when you're near water, snow, and sand because the sun's rays are reflected. Additionally, avoid tanning beds because that will cause skin cancer and premature skin aging. And if you want to tan, you can use self-tanning products, but also you have to continue using sunscreen. And going back to the skin checks, you should do monthly skin exams. About 1 in 5 people will get skin cancer, and if it's caught early, it's highly treatable. Melanoma is the deadliest. And as far as doing the skin checks, you should do a head-to-toe skin check, and you should make sure you look at the front and back of your body. And one of the things I would recommend is having a partner look at it, look at the areas that are hard to see, such as the back of your neck, or you can use a mirror.
One thing I think that's also important to mention about melanoma is that they do not have to be sun-exposed areas like with basal cell and squamous cell carcinomas. So they can pop up, in your mucous membranes, on things like your fingernails, nail beds. Bob Marley actually had melanoma on the bottom of his foot that looked like a bruise, and so it actually didn't get caught because of that reason. So just something to be aware of.
Yeah, unfortunately, in my family, my dad ended up having the melanoma, and he ended up getting it resected, and luckily that was curative. But I did have an uncle who passed away because it was so severe of melanoma. So there's definitely, it does kind of run in the family. So make sure that if you have relatives who've had melanoma, that you should talk to your doctor about that. Now, does the United States Task Force for Prevention recommend skincare, skin checks, and doctor-guided skin checks, or do they depends on the patient and the time?
I think you're supposed to see like a dermatologist once a year.
Annually, yep.
Yeah.
So I thought that the United States Task Force did not quantify or like regularly recommend skin checks. It was not offered as a recommendation, as a guideline, like a permanent guideline. But of course, anybody who has fair skin or multiple skin spots or nevi, I guess they call them, and also family history of skin cancer, or if they personally have had skin cancer, they should have those checked yearly, if not more frequently, and they also should do self-exams. But I believe in general, my understanding is that skin checks were not necessarily recommended as a guideline for that. But what we'll do is we'll take a look and we'll follow that up in the show notes if it's incorrect. But anyway, interesting guidelines. We usually follow the ones that we recommend in the office, and they still, those guidelines are just there for guidelines, so you can do more or less depending on. I mean, on my physical examination, I don't know if I check every patient and have them do a full body check with their skin. So I'm not quite sure if that's still recommended. Did you guys find that in your other practices that they did full body skin checks, or only at the dermatologist?
Only at the dermatologist. They'd come in specifically for a skin check, and then if they have like melanoma, they have to come in every 6 months or sooner, depending on how fast it's growing.
Absolutely. Yeah. And in your primary care offices, though, did they do that for routine physicals?
No,
they would take a look at, suspicious if the patient brought it up. But
absolutely, I think that when I do the examination, if the patient brings up any chance of skin cancer, or concerns about a skin spot, I tend to err on the side of caution and biopsy that. So, anyway, think about that when you guys are also doing your physical exams. If you want to include that in your physical exam, that could be part of a maybe more thorough physical examination. And I would personally recommend it for people who you suspect have multiple nevi on their bodies, multiple skin spots. Those are the ones that end up having higher risk factors. Do you know what the risk factors are for skin cancer? Let's start with maybe
genetic, 10% for melanoma at least. The other risk factors, the sun. I think that's the highest one.
Having fair skin, typically.
And then even if you don't have fair skin, you still have a chance of getting skin cancer. I think those are the main ones.
Yeah, I agree. I think that, you have some risk factor. And what about...
And the multiple nevi.
How about smoking or... no?
I don't think so. I don't remember smoking.
Now, I've read somewhere that scarring, or there's multiple scars, might also increase your risk. Is that correct?
Yeah, in that area, or burns.
Oh, yeah, multiple burns on that area. Yeah, because maybe the skin gets a little bit less able to handle sun, in those areas where there's scarring, less melanin, melatonin, right? Melanin, yeah.
When most of that damage is usually done, I think, before the age of 18.
No way.
Yeah, it is, With
So in this case, you think that you're going to have a couple of years of protection, but you got to use that right away.
Yes.
So definitely young kids you should be more aggressive with.
I think we're a lot better about that now. Like our parents' generation, really SPF was not done or used, and so hopefully we'll see a decline in skin cancer, very preventable.
Absolutely.
Disease.
Are you guys following the global warming and seeing if that might have an increased effect on our skin damage? Is that...
Ooh,
That's interesting.
Sure.
I'm sure with the ozone, there would be implications.
Maybe less.
Yeah.
I don't know. That is interesting. But I know when I did my dermatology rotation, for guys, they don't like how the sunscreen feels. So I think it's...
I think you have to be careful because some of the sunscreens can clog the pores and kind of create worse skin, irritation. Yeah. And some people are allergic, especially if they're fragranced or something like that. So I usually recommend.
I like the clothing for guys.
The clothing.
Yeah.
So the SPF protective gear.
Yeah, especially if they don't like putting on the because it can get sticky.
Mm-hmm.
I think a lot of guys don't like to put on sunscreen.
I wonder, like with the young kids, you can just put those SPF shirts on and then try to spray them down with the spray. Have you tried that spray one?
Yeah, I like this spray.
Yeah, it does make it a little easier to apply for those kids, and
Feels
you're trying to
better.
run around and you got to grab them and put the sunscreen on. So
Especially when you're playing around and splashing, and you do have to reapply.
absolutely, yeah, that's true.
Which I think that gets a lot of people too.
Yes, I don't think a lot of people reapply.
No.
How would you guys diagnose skin cancer?
You have to do a biopsy.
How's that
You
done in
just-
the office?
You just cut a little. You have to take a sample of that area. Not really a sample. You remove the mole,
Okay.
and then you send
You
it
just
to
how would they prepare for that?
for the biopsy.
Mm-hmm. Yeah.
We just numb the area, and then it gets cut
How do you numb the area?
with lidocaine.
Okay. Is that
And-
just application topical or?
No, with a needle.
Okay.
And then if it's very small, sometimes, because there are different types of skin cancers, you can also cut it off with like scissors or depending. I think most places they do biopsies to make sure it is not cancerous, because they don't all look the same.
Mm-hmm.
And then, but if you are removing a mole, you inject lidocaine and it gets numbed up, and then you can cut it off
Mm-hmm.
and then send it off for biopsy. And
Yeah.
the pathology report usually comes back
Okay.
and states what it is.
And then once you have like the diagnosis, what do you do next?
Well, you depending on where it's located, they might get Mohs surgery on the face.
Where would okay, so
on
the face, right?
Yeah, like
Yeah.
sensitive areas.
I was told that,
Vascular areas, particularly.
and I was told that in most particularly you'd want to get this triangle region here. Is that because that more likely to metastasize if it's found, or is it that you have more sensitive structures there, so you want to make sure that you cut as minimally, the most amount
Yes.
needed to treat the condition, but to also make sure that they're not
Yes.
over cutting.
That was
Is
my
right?
understanding of it, especially because there's not a lot of room to work around with the face,
Sure.
and it's very, cosmetically.
Yeah. Why wouldn't we use Mohs surgery for everything then?
It's not necessary. I think it's pretty expensive. It's pretty time intensive because you're taking
Takes all
little
day.
slices, and a pathologist is looking and analyzing those. So
I always tell the patients too that maybe 99 to 100% of the cases, these skin cancers tend to grow outward. So they're not going back into the skin or into the body, but the local changes are going to be where you see that the most. So if you have a patient who has a small spot that's growing on their skin, it's likely it's going to keep growing outside, and you'll see it and have to cut it out eventually, or it can significantly impact the anatomy of your body if you just let it go. I did have a patient. One of my big cases when I was in residency was a patient who had let a squamous cell cancer grow so large that it took over like almost all of his shoulder. He had to get
jeez.
deep tissue resection, right, including the muscles, and then we had to take a flap from another part of his body and replace it.
Yeah.
And this is an interesting story. So like I ended up working at another facility, and like 10 years later in the second facility he came, and which completely like not in the same even town. And then on the third occasion he met me up here in Tampa, completely coincidental, and I ended up treating him 3 times, and it was my patient from way back in the day from where I started doing my residency. So that was kind of a very weird situation. When it happened the third time, I had a feeling something was like some alignment of the stars was happening, because it was just unusual. But I did a special case on him, and he did have squamous cell, which was resected, but poor guy, but ended up everything was fine at the end, thank God.
Oh, that's good. Yeah.
So yeah, and okay, so what do you guys recommend? I think we already talked about skin screening, right? We also talked about skin cancers, the A, B, C, D, E's now.
Of
skin
melanoma.
Of melanoma.
One type of skin cancer, yes.
Oh, okay.
Yes. So there are other types that you mentioned with the squamous cell and basal cell. Those do tend to present a little bit differently. The basal cell can be, kind of a pink red papule, sometimes has ulcerating, section in it. So anything that's like oozing or bleeding, itching, just kind of smooth on the surface with telangiectasia, so little blood vessels around it. That's also something to be aware of. And then the squamous cell that you were mentioning earlier, that can even arise from a benign condition, seborrheic keratosis.
Actinic keratosis.
Actinic keratosis,
right.
yes.
And that,
yes.
I think we call them precancers, so
right.
maybe not completely benign, but yes, I agree.
Right, both of those are. So, which can be kind of rough looking.
How do we treat the actinic keratoses? And I'm sorry, go ahead. I interrupted.
No, you're good. Yeah, topical agents is typically the main.
But you were describing the squamous cell?
Yes.
What would look like ulcerated?
Yes, kind of patchy, flaky, not to be confused with the seborrheic, which is kind of waxy, stuck on looking. Those are completely normal. A lot of people have those. Age spots is what they're called. And
when we do have actinic keratoses, how do we treat that?
Cryo.
We do the liquid nitrogen here, and you also mentioned some creams like 5-fluorouracil.
Yes.
And then I ended up also, so once we have a diagnosis of, let's say, squamous cell or basal cell, what do? Do you go back and resect the region, or do you...
No, you have to look at the margins. You make sure you take enough margins. And then...
How would you do that?
When you do the excisional, the biopsy, you have...
Is there a rough rule as to the margins?
It depends what kind of... Like, I know with melanoma, if it's less than 1 millimeter, I think it's like 1 centimeter. That is kind of big for melanoma. And then the bigger it is, the wider the margin. And so when you send the report to pathology, they tell you if there's any cancer in the margin. So if there is, you have to go back and do more excisions.
Is that true though for basal and squamous cell? Do you have to do the margins, or
I think
can
you
you
still have to do margins for all of them.
I'm not sure.
Have you seen them just simply do more destructive measures, right? So with the hypercator perhaps, or they call it desiccation and curette, or curette and desiccation, and they say they do 2 or 3 times, and you can get to that core, and then you pretty much monitor that spot. So there are different schools of thinking about how you should treat these, and I've had cases where I've done resections, and I've also had cases where I've just simply kind of scraped it down. So I mean, you could use your best judgment and then use all of the studies to determine what's best for your practice.
And usually, I mean, you have them come back.
So you worked at the dermatologist, right? And is that what he did? He brought him back every time and did the resection?
If the margins were clear, they didn't come back.
Oh, okay.
So
on his biopsies, do you think he would be more aggressive with his biopsies then?
If it's like melanoma, then he's definitely a lot more aggressive with melanoma. But he was, if it was really small, he's done the curette.
Sure.
And then...
What if it's dysplastic nevus? Have you guys heard of this?
The dysplastic nevus?
So
yes.
Okay.
No, but go ahead.
No, well, the dysplastic nevus is basically that in between. We don't know which direction this lesion is going to go. So it's possible that it may be completely benign and we should leave it alone. Others say that we should resect it. Others say that we should biopsy it and recheck it in 6 months. So again, that's also controversial, but some people consider dysplastic nevi cancer in some cases, but in some other schools of thoughts have said that that's benign. I would just talk to your dermatologist or your primary care doctor about that, and anything that's changing on your body, I would definitely ask him, maybe biopsy it, take a look, depending on how aggressive you want to be. So I know that there's a lot of schools of thought on how to kind of treat cancer in general. Do you guys recommend one sort of treatment over another when it comes to skin cancer? So I know that there's, for example, the Moffitt Cancer Center that's local, and they're kind of aggressive. They do radiation, chemo sometimes even. Do you guys are aware of any treatment protocols or?
I think I know that you start off with the biopsy and the margins, and then if it has spread, you might have to do like a lymph node biopsy as well, and then you move on to like radiation and chemo.
And that's specific for melanoma because I know that the squamous cell and the basal cells are not.
They're not as invasive.
They're not as invasive.
Yeah.
Yeah.
And I think one thing to keep in mind for patients is like if you have like a pimple or a mole that doesn't seem to be healing, like for months or like weeks, you should definitely come back to your primary care provider or dermatologist and have them take a look at it.
Have you guys seen some patients with cancers here, any skin cancers, and have we treated any?
Oh, here?
Of course.
Yeah. Yes.
I know we did
Yes,
some.
we did. Yeah, we did one. We did a biopsy on one.
Yeah, that's true. Then we also did some liquid nitrogen a lot.
Yes. Yeah.
Any remaining thoughts or questions about skin cancer and skin cancer screening? Any final remarks regarding? Did you guys have any experiences in your practice during your rotations where you saw some cancer that was out of the ordinary or concerning?
There was one like fungal cancer, but it was really hard to tell, and it was pretty large, but it didn't look cancerous.
Wasn't it mycosis fungoides? Have you heard of that?
Maybe, but it was pretty big.
Yeah, there's used to be. I also had another condition where this is called mycosis fungoides, and this was what was thought to be something related to, with mycosis being fungal, but it ended up actually being a type of cancer.
Yeah, T-cell lymphoma.
Yeah. So that wasn't the fungal cancer. It's a fungal cancer.
I couldn't remember, but it didn't look cancerous. Like it doesn't have the typical ulcerated look.
Oh wow!
But it was a pretty large size. But that's why it's important, to do skin checks.
Gotcha. Yeah. I mean, it's still a complicated situation with skin cancer in general. But let's go back and see what the United States Task Force for Prevention recommends. I don't know if you want to look it up now. We can kind of like finalize the podcast. But aside from the skin cancers, and is there anything in specific that you guys felt was the biggest concern in terms of the A, B, C, D, E's? Anything that was one that kind of seemed to be the most important over the others, or
the evolving?
The evolving.
That's the main one. If it keeps changing.
And I've seen many cases where I've seen 2 or 3 different colors, and the way I kind of, recommend screening when you're dealing with physical exams is take a look at the whole body. And when you look at the whole body, you'll see different nevi, and 1 or 2 that might stand out. And especially if these 2 or 3 stand out, definitely magnify that. So I have something called the dermatoscope. And the dermatoscope I use to magnify lesions that I'm concerned about. Technology now may allow us to, and I've kind of been using my cell phone, believe it or not, to take pictures of lesions. And you can follow it up with serial pictures, and you can compare them from previous, and if they're changing, that may push you further to take a biopsy. So I think that was very well said, that the most important factor isn't like a nevi that's just has all the ABCDs, but that evolving portion really makes a big difference for my practice. Any thoughts on the United States Task Force?
Yeah, they just basically say that the current evidence is insufficient to assess the balance of benefits versus harms of visual skin exam. So
yeah, I had read that and I was like quite surprised, because we are screening. There's a lot of little things that we do screening, and they found evidence conclusively that it has helped. So I think depression screening, for example, has helped in certain age populations. Cholesterol screenings in certain patient populations. Age appropriate screenings were also considered. But yeah, so skin cancer, even though we probably think it's one of the most important things, it's not. Still, evidence doesn't show the benefits versus risks, but I think in your practice you'll be the one to judge, I think. Well, thank you guys for coming on the podcast. We'll sure to Enjoy the rest of the podcast, you guys. This is Dr. Jonathan Youssef, networking for your optimal health.